this video, we'll discuss how drugs are eliminated from the body. In the last video on drug delivery, we began our discussion of pharmacokinetics, which is the study of what the body does to the drug. We focused primarily on the processes of absorption and distribution, which describe how a drug moves from outside of the body to systemic circulation and to various tissues to reach its eventual site of action. In this video, we'll focus on metabolism and elimination, which are both processes that reduce the functional drug concentration in the body. The efficiency at which this decrease in functional drug concentration occurs is referred to as clearance. Greater clearance means more drug is removed from the body in a given interval of time. Now, importantly, clearance only refers to the irreversible elimination of drug. So this is either drug that's been chemically altered from its original form by metabolism, or a drug that has been completely removed from the body. Any drug that is reversibly removed from circulation, such as drugs that have distributed to a tissue other than the site of action, is not considered cleared because that drug could still re-enter circulation, reach its site of action, and be functional at that site. There are two major organ systems that participate in clearance. We'll focus first on hepatic clearance, which refers to the metabolism of drugs done by the liver. One of the major roles of the liver is to remove foreign substances that might be toxic from the body, and the liver can't necessarily tell the difference between an ingested molecule that is a toxin and an ingested molecule that is a therapeutic. So drugs that make their way to the liver will undergo hepatic metabolism, which occurs in the smooth endoplasmic reticulum of hepatocytes. The goal of liver metabolism is to make a drug more soluble in water so that it can be eliminated in the urine. There's two major phases of liver metabolism, phase 1 and phase 2, and drugs can either undergo just phase 1, just phase 2, or phase 1 followed by phase 2. Phase 1 metabolic reactions, which lead to either oxidation, reduction, or hydrolysis of the drug, are performed by a group of enzymes known as cytochrome P450 enzymes. By oxidizing, reducing, or hydrolyzing a drug, these enzymes convert the drug to an inactive metabolite. Now, I say inactive meaning that the drug can no longer serve its intended function at its site of action, but the metabolite may still have biological activity. Ironically, cytochrome P450 enzymes can sometimes metabolize drugs into toxins. A high-yield example of this is the metabolism of the commonly used analgesic acetaminophen into the toxin N-acetyl P-benzoquinone imine, which I'll just call NAPQI from now on. At therapeutic doses, only a small amount of acetaminophen is metabolized by phase 1 enzymes, and the toxin is produced in small amounts that can be rapidly detoxified. But at very high doses, much more NAPQI is produced, which leads to a lot of oxidative stress and binds up all of the glutathione in the liver, which can lead to fulminant liver failure. Replenishing the liver's glutathione stores by administering acetylcysteine detoxifies NAPQI. Phase 2 metabolism involves the conjugation of a functional group to the drug, and this is done by a wide variety of other enzymes in the liver. Drugs can enter phase 2 metabolism either after undergoing phase 1 metabolism, or they can go straight from the bloodstream to phase 2 metabolism without undergoing phase 1 metabolism. An example of a phase 2 enzyme is UDP glucuronol transferase, which transfers glucuronic acid to drugs. Glucuronidation is required for the metabolism of bilirubin, and a defect in the enzyme that performs this function can lead to unconjugated hyperbilirubinemia, also known as Gilbert syndrome or the more severe Crigler-Najjar syndrome. UDP glucuronol transferases are also responsible for metabolizing the antibiotic chloramphenicol, which is implicated in something known as gray baby syndrome. Infants, and in particular premature infants, often have underdeveloped UDP glucuronol transferases, which means that chloramphenicol cannot be eliminated efficiently. This leads to accumulation of the antibiotic in the body and causes ashen skin, irregular respiration, and hypotension. So chloramphenicol should be avoided in neonates, and especially if premature. UDP glucuronol transferase is probably the highest yield phase 2 metabolic enzyme, but other reactions that can be performed by other types of enzymes include acetylation, sulfation, and methylation. And again, the point of all of this is to make the drug more soluble in water. We already talked about first-pass metabolism in the video on drug delivery, But to review, first-pass metabolism refers to the fact that any drug that passes through portal circulation prior to entering systemic circulation will have already undergone liver metabolism by the time it reaches its site of action. So most oral drugs which go through the liver prior to entering systemic circulation have already had the opportunity to be metabolized by the time they reach their site of action. This decreases how much drug is able to get to the target site in its functional form, otherwise known as a decrease in bioavailability. To get around this problem, some oral drugs are designed as prodrugs. Prodrugs are inactive in their original form, but become active once they've undergone metabolism in the liver. For example, the initial form of the platelet inhibitor clopidogrel in its oral pill is inactive, but once it undergoes a series of oxidative steps in the liver, it becomes active. This approach gets around the usual decrease in bioavailability due to first-pass metabolism and actually increases the bioavailability by taking advantage of the reactions that occur in hepatic metabolism. Let's move on now to the second part of clearance, which is actually getting the drug and its metabolites out of the body. First, let's consider what is now in the bloodstream after hepatic clearance has occurred. So we have this blue drug, which underwent both phase 1 metabolism and phase 2 metabolism. Now it's soluble enough to be eliminated in urine. We have this pink drug, which did not need to undergo phase 1 metabolism, but did undergo phase 2 metabolism. There's going to be some drugs that just need to undergo phase 1 metabolism in the liver in order to be secreted in the urine. And finally, there are some drugs that are actually aqueously soluble enough to be eliminated in the urine without even needing to undergo hepatic metabolism. The next step for our aqueously soluble drugs and their metabolites to be eliminated is to go through the kidneys. The kidneys are primarily responsible for eliminating drug in the urine. Kidneys are composed of nephrons, which are these complex tubular systems that filter blood in order to create urine. We won't go into how this works in detail here, but you can check out our renal video series for more information. For our purposes here, we just need to know that the kidneys can take the aqueously soluble drug, whether that's in its original form or in its hepatically metabolized form, and filter them into the urine in order to be removed from the body. Renal clearance can be calculated by taking the volume of distribution of the drug and multiplying by the elimination constant, or by taking the urine drug concentration multiplied by the urine flow rate and dividing that product by the plasma drug concentration. The renal video series discusses this in a lot more detail. So now we followed the journey of the drug from outside of the body into systemic circulation and its eventual site of action, as well as how it becomes metabolized by the liver and eventually leaves the body through the urine. Just to complete this picture, some drugs are going to be actively secreted by hepatocytes into the bile produced by the gallbladder, and this drug is going to leave the body through feces instead of urine. So to summarize what we've talked about in this video, clearance describes the irreversible removal of functional drug from systemic circulation, either through metabolism or elimination. The primary organ systems involved in this process are the liver, which metabolizes drugs into more aqueously soluble compounds, and the kidneys, which eliminate the drug or its aqueously soluble metabolites through the urine. One thing that's important to keep in mind is that any diseases that affect the function of the liver or the kidneys is going to decrease the ability of these organs to clear drugs. This means the dosage of many drugs will need to be adjusted down in order to avoid causing toxic levels to accumulate in the bloodstream. Function of both of these organs also naturally declines with age, so the dosage of many drugs needs to be adjusted down for elderly patients.